spinal cord injury. In spite of many decades of active research, spinal cord injury is still to be considered as a devastating disease that affects mainly adolescents and young adults with many years of future. Here we can see the percentage of males to females, and we can see the prevalence in males in all modes of trauma. We have some definitions to know and memorize in the issue. The incomplete spinal cord injury is the type where there is any residual motor or sensory function below the level of the lesion, and actually we start counting starting from 3 segments below the level of the lesion. Sacral sparing is an included sign, so whenever there is sacral sparing, it is an incomplete spinal cord injury. However, the sacral reflex alone are not a sign of incomplete lesion. We have some types. The most important are central cord syndrome, Brown Sequard cord syndrome, anterior cord syndrome, and posterior cord syndrome in relation to the anatomical distribution of the lesion. Complete lesion is that where there is no preservation of any motor or sensory function below the level of the lesion, provided that there is no spinal shock. And actually, again, we are counting starting from 3 segments below the level of the lesion. Here is the ASIA, American Spinal Injury Association, for the impairment scale grading here, did another classification that is more individualized, I mean more detailed, where there is complete lesion, where there is no motor or sensory function preserved. It is considered A. A is the worst one, and E is the best one with normal power and sensations, and in between we have some grades according to the preserved number of key muscles, and here are the key muscles considered in the classification. The spinal shock is a term to be used in 2 different classes. The most famous one since the undergraduate study is the vascular shock, where the systolic blood pressure is around 80 millimeter mercury due to interruption of sympathetic, pooling of blood due to in the lower limbs due to loss of muscle tone, or real true hypovolemia due to loss of blood from associated injuries. The neurogenic shock is of poor prognosis. It is transient loss of all neurologic function below the spinal level of spinal cord injury, leading to flaccid paralysis and areflexia. The duration may be 72 hours. It's commonly 1 to 2 weeks and occasionally months. It is accompanied by loss of bulbocavernosus reflex, and whenever it resolves, the spasticity appears below the level of the lesion and the bulbocavernous reflex starts to return. The bulbocavernous reflex is a polysynaptic spinal cord mediated reflex. It is mediated and relayed via S2 and 4 nerve roots. The reflex has a stimulus through the squeezing of glans penis or tugging of the Foley's catheter, and the response is contraction of both anal and external, both external and internal anal sphincter. So we have 2 hands, one is testing and one stimulating the glans penis, and the other is testing the anal sphincter. The loss of the reflex occurs in spinal shock or in injuries involving coda equina or conus medullaris. Here we can see the shape of the image that illustrates. Here we have one hand testing the anal sphincter while the other is stimulating the glans penis. Here we can see the central cord syndrome, the anterior cord syndrome, and the Brown Sequard syndrome. The posterior cord syndrome, and another one will be illustrated later. Here we can see axial cut for the spinal cord, and we can see both ascending and descending tracts and the distribution of each. And it's important to notice that the sacral segments, sacral fibers are located at the periphery, while the cervical fibers are located near to the center, here in both ascending and descending tracts, which will affect the clinical picture of syndromes of incomplete injuries. Central cord syndrome, we can see here the central cord syndrome in sagittal T2 MRI. Central cord syndrome is a relatively favorable is a syndrome with relatively favorable prognosis for recovery. The most common type of incomplete spinal cord injury is central cord syndrome, especially in elderly. The mechanism of injury is usually hyperextension of an already stenotic spinal canal, commonly the cervical spinal canal. Recovery occurs more favorably in younger patients. There is an incidence between 87% and 97% of patients younger than 50 years that will eventually ambulate, while those older than 50 years, the percentage is 31 to 41%. Lumbar and sacral fibers, as we mentioned, so the weakness of the upper extremities greater than the lower extremities, and there is sacral sparing. Hand intrinsic function is the last to recover and usually incompletely in all ages. This picture mimics syringomyelia, as the pathology of both is central or near to the center of the spinal cord. The treatment of spinal cord syndrome. We have to know the rule that there is no rule for surgery without ongoing cord compression or instability. Timing is important to know for patients with ongoing spinal cord compression. The emergency surgery is indicated where there is documented progressive deterioration. And early surgery is to be considered, which is first 24 hours for the spinal instability or patients with long tract findings. And patients that are improving can be operated electively to decompress the cord. Anterior cord syndrome, actually we can see here the anterior part of the spinal cord in the thoracic area in sagittal MRI, and here's the axial MRI with anterior cord syndrome. Anterior cord syndrome, the prognosis is poor, it's relatively poor. This is an injury to the anterior two-thirds of the spinal cord, including both gray and white matter. The posterior column is preserved and it has its own syndrome. Cervical or thoracic fracture with retrobulging of disc or bony fragment can cause the anterior spinal cord syndrome. Also lesions of the anterior spinal artery. Most commonly complete paralysis with spasticity. In the lower extremities, deep pressure and proprioception are preserved. As we can see here, the prognosis is poor. Only 10 to 20% of anterior cord syndrome patients recover functional motor control. Sensation may return enough only to help prevent injuries like burns and decubitus ulcers. Again, it is of relatively poor prognosis, the anterior cord syndrome. The treatment is surgical intervention for those cases with evidence of spinal cord compression like those of fragment, bony fragment or disc fragment. The Brown-Sequard syndrome, here we can see the hemisection of the cord in axial MRI at the level of C6. Brown-Sequard syndrome is the greatest potential for functional outcome and ambulation, 75 to 90% of recovery. This injury occurs with functional hemisection of the spinal cord, Most common causes are gunshot or knife wound. The classic presentation is ipsilateral loss of motor function, ipsilateral of loss of dorsal column sensation, and contralateral loss of pain and temperature below the level of the lesion. And can be viewed in the axial cut for the ascending and descending tract mentioned previously. Bowel and bladder continence is regained in 82 and 89% respectively. The posterior cord syndrome here is a rare syndrome, and we can see here the posterior affection of the cord in cervical, thoracic areas. Actually, this is a degenerative case, and here was given as an example only for imaging. And here is the site of the pathology in spinal and posterior cord syndrome. The least common incomplete spinal cord injury, as we mentioned, it is characterized by absence of position sense. Here is usually preservation of pain temperature and touch. The motor function is impaired to variable extents. Here we can see the diagram that shows the management of spinal cord injury. When the general rules, do not forget the patient is telling I'm a multiple trauma patient, airway, breathing, circulation, decontamination, and exposure. These are the rules of multiple trauma patients. Immobilization, either cervical or others. Imaging is an important issue. The medications, most of them are becoming obsolete right now and debatable, and we will mention here. The skull traction will be discussed also on the timing of surgery here. This is a funny diagram, but is showing the outlines. ABCs and triage. If there is no history of significant trauma, the patient is completely alert-oriented and free of drug and alcohol intoxication with no complaints, so can be cleared clinically without the need for imaging. If there is significant trauma but no strong evidence of spine or spinal cord injury, we have to rule out bony lesion and prevent injury. In patients with neurologic deficit, define the injury, the skeletal injury, and prevent further injury and minimize or reverse the deficit which happened. Here is immobilization, stabilization, followed by neurological examination. Cervical collar for the cervical region and others for others. This is a board for the lumbar and thoracic. The immobilization using rigid collar board or sandbag, the stabilization for the blood pressure but avoid phenylephrine, and maintain oxygenation and be cautious during intubation for the hyperextension that causes more injury. And the neurological examination including local spinal column examination and others. Cervical immobilization. Cervical collars should be removed as soon as it can be determined that it is safe to do so. It is not indicated when the patient is asymptomatic, or penetrating brain trauma, or patients awake with neck pain tenderness and there is normal CT scan after doing flexion and extension x-rays or MRI or normal MRI. Cervical immobilization in obtunded patients with normal CT cervical scan and gross movements of the all of the four extremities. Flexion and extension cervical x-rays shouldn't be performed. Sorry. Options: maintain cervical collar until a clinical examination can be performed, or remove the collar on the basis of the normal CT scan alone, or obtain cervical MRI. If the MRI is normal, the collar can be safely removed. Here is the radiographic evaluation. In awake asymptomatic patients with no neurologic deficit and no significant associated injuries, no need for imaging. Imaging in obtunded patients or unavailable, high quality CT is the modality of choice. High quality CT imaging is if high quality CT imaging is not available, 3-view cervical spine X-ray, which is AP lateral and open mouth to the odontoid, are recommended. If high quality CT is normal, we can continue cervical immobilization until the patient is asymptomatic, or obtain cervical MRI within 48 hours of injury, and if normal, discontinue immobilization or discontinue cervical immobilization based on the treating physician decision. Here we can see the CT, cervical spine, sagittal axial, CT cervical spine, sagittal coronal, and here we can see the sagittal CT with this horrible dislocation, and we can notice how far will be the problem in comatose patient. When CT scan is not appropriate or available as the initial radiographic examination, apply the following. Cervical spine, for those the cervical spine must be cleared radiographically from the craniocervical junction down to the cervicothoracic junction. We can do lateral portable cervical spine X-ray while in rigid collar. This study by itself will miss like 15% of injuries if all cervical vertebrae and cervicothoracic junction are adequately visualized and are normal, and if the patient has no neck pain or tenderness and neurologically intact, then AP and open mouth view can be done. Here's the open mouth view. We can see the C1 lateral mass, the odontoid process, the C2 spinous process, and here's the AP view of the cervical spine. Here's the open mouth and lateral cervical spine in C2 fracture. If the previous studies are normal but there is neck pain, tenderness, or neurologic finding, or the patient is unable to reliably verbalize for the neck pain or cannot be examined for neurologic deficit, then oblique views, flexion extension views, CT, MRI, polytomograms, or pillar view are done. If subluxation is present at any level and is less than 3.5 millimeter and patient is neurologically intact, we can do flexion and extension views. If no pathologic movement, discontinue the collar. May need delayed films once pain and muscle spasm have resolved to reveal instability. The last step in cervical spine. If lower cervical spine and or cervicothoracic junction are not well visualized, repeat with swimmer's view or CT 3D with reconstruction. Also, we can track the arms. When CT scan is not appropriate or available as initial radiographic examination, apply the following. This for thoracic and lumbosacral spine. AP and lateral X-rays for all trauma patients who were thrown from the vehicle or fell down from 6 feet height or more to the ground, complain of back pain or unconscious or unable to reliably describe back pain, or have a known mechanism of injury or other injuries that cast suspicion of spine injury. Here we can see the AP thoracic and lateral thoracic spine with wedging of T7. When bony fracture or neurologic deficit, do not do CT or MRI. So whenever we have bony fracture or deficit, we have to do CT or MRI. The deflection extension X-rays are contraindicated whenever the patient is not cooperative, subluxation more than 3.5 millimeters, or there is neurological deficit. We can see here the flexion extension, we can see the subluxation, and we can see here how far was it. It was risky, and I think it is more than 3.5 millimeters, and it was done by mistake in this case. Emergent MRI is indicated in this situation when there is incomplete spinal cord injury or neurologic deterioration, or there is neurologic deficit that not explained by radiologic findings. Non-emergent MRI is indicated in inconclusive cervical spine radiography, significant midline paraspinal tenderness, and patient is unable to have flexion extension X-rays, obtunded or comatose patients. We can see here the sagittal, cervical, thoracic, and lumbar MRI in trauma patients. We can see here the medications, and most of them are debatable. As we mentioned, steroids are no more recommended or are not more recommended by most of the associations, and so we can see that finally the American Association of Neurosurgery guidelines changed methylprednisolone from a treatment option to a level 1 recommendation against use. Also, the same is applied for GM1 ganglioside. Again, not more recommended or no more recommended. Hypothermia, either local or systemic, is another mode of treatment, and it is more promising than the previously mentioned medications, but still not approved as a modality of treatment, still to be considered for more studies and more testing. The traction and reduction for spinal cord injuries. The guidelines has many controversies. Early closed reduction of cervical spine fracture dislocation injuries with craniocervical traction to restore anatomic alignment in awake patients. The diagnostic evaluation should consider MRI to be done to avoid complications before the traction. Atlanto-occipital dislocation is a contraindication. And also the other contraindications are type 2A or 3 hangman's fracture, local problems in the skull, extremes of age, old ages and infants, patients with an additional rostral injury. So whenever the patient has two injuries in the cervical spine, avoid traction because the proximal part will cause many complications. Patients with movement disorders. Here's the Gardner-Will tongue, the most important, the most famous one. Pin sites in Gardner-Will's tongue. The pins are placed in the temporal ridge above the temporalis muscle, 2 to 3 finger braids above the pinna, and to be placed directly above external acoustic meatus for neutral position, or 3 centimeters posterior for flexion in case of locked facets, or 3 centimeters anterior for extension. Here we can see the sides of halo. The halo ring may be used for the initial cervical traction and then converted to halo vest. Here is the halo ring and the safe place. Here is the halo ring. And the ring size should be about 1 centimeter and make about 1 centimeter to 2 centimeters gap between the scalp and the ring. The ring position is usually generally to be placed at or just below the widest portion of the skull, 1 centimeter above the orbital rim, and this is anteriorly and posteriorly should be 1 centimeter above the pin. The sides, the anterior pins are placed above the lateral 2/3 of the orbit. Posterior pins are just above the ears, and in pediatrics, additional pins may be placed to further distribute the load to the skull. The traction to be used, actually, you have to memorize the number 10 all the time. X-rays. Lateral cervical spine X-rays are done immediately after application of the traction at regular intervals and after every change in weight and recovery from and every move from bed to check the alignment and rule out over distraction. The weight to be used if there is no malalignment and the traction is to stabilize the injury and compensate for ligaments instability. Use 5 pounds for upper cervical and 10 pounds for lower cervical spine injuries. And we can remove cervical collar once the patient is in traction with adequate reduction or stabilization. Here's the retraction figure. The traction for locked facets has the following rules. The initial weight is 3 multiplied by the cervical vertebral level, increase in 5 to 10 pounds at 10 to 15 minutes interval until desired alignment is attained. And we have to assess neurologically, neurophysiologically, and X-ray can be used. When to stop. we have to stop, and we cannot exceed 10 pounds per vertebral level. Some say 5 pounds per each level under most circumstances. And also 10 millimeter over distraction is an indication to stop the traction in neurologic deterioration also, and at occipitocervical immobility, instability. Here we can see the Helovist shape, and after transformation of the halo ring to Helovist, I mean the halo ring traction to Helovist fixation. Timing for surgery after spinal cord injury. There is an important warning to know that decompression alone may cause deterioration, so should be associated with stabilization procedure. Contraindication to emergency surgery are complete spinal cord injury, more than 24 hours, medically unstable patient, and the central cord syndrome, which is controversial as we mentioned before. Here are the modified Schneider's recommendations. In patients with complete spinal cord lesions, no study has demonstrated improvement in neurologic outcome with either open decompression or closed reduction. So whenever there is complete spinal cord injury, there is no rule for surgery for neurologic issues. Surgery is reserved for incomplete lesions, possibly excluding central cord syndrome with extrinsic compression who following maximal possible reduction of subluxation show the following: progression of neurologic signs, complete subarachnoid block, compression of spinal cord, necessity for decompression of vital cervical root, compound fracture or penetrating trauma of the spine, acute anterior spinal cord syndrome, or non-reducible fracture dislocations from locked facets causing spinal cord compression. Thank you very much.